Hi, everyone. Thank you so much for joining today. It's nice to be with you all. Just going to give a couple more minutes to let folks trickle in. We'll plan to start in just a couple minutes, but really so nice to see all of you here showing up for this. I see a lot of familiar faces or names and some new names. So nice to be with you all. We'll get started in just a couple minutes after we allow a few more people to sign on. See how we're doing on time.
We're good, Ari.
Thank you. Hi, everyone. Thanks for coming. Let's see how we're doing. Sorry, the silence is so hard for me. I just need to keep saying things. Next time we'll put music on as people come in. All right. The number of people entering has kind of slowed down. What do you think, Bella? Shall we get started?
Let's do it.
Okay. And you can continue to let people in, right? Okay, perfect.
Yes, yes.
All righty. Well, everyone, welcome. Thank you so much for coming today to our webinar, Evidence-Based Approaches to Drug Policy, a Roadmap for Minnesota. I'm here presenting with my colleague, Ann Siegler. She and I are the co-authors of these two reports that we're really excited to walk you through today. Let's see. Next slide, please, Bella. Bella is our brilliant communications and tech support person today. Bella, so glad to have you here helping us out. She sits in Burlington, Vermont, but is a lover of Minnesota. So just a brief agenda about what we're going to do today. We're going to talk about the background of the report, where it came from, why we wrote it. And then the heart of the presentation is really what we found and describing which drug policy approaches are supported by the evidence and which are not. And then excitingly too, we're going to give you just a snapshot of some of the 150 recommendations that Ann and I put together in these reports. And then also, very excitingly, we have some guest spots with experts in the field who are here with us today. Jack Martin, John Tribbett, Jason Urbanchik, and Lauren Graber are going to be joining us to kind of bring the reports to life. So just a bit about Ann and me. We are both drug policy researchers. Ann has a background in epidemiology. I'm more on the policy side, but we are researchers by training in addition to doing some other things on the side. We're going to have time at the end of this report or at the end of this presentation for questions, just a few minutes for questions. So as you have them, put them in the chat and Bella is going to help us collate them and respond to them at the end. Bella is also going to put the event guidelines in the chat if she hasn't done so yet. Oh, yep. So some language about maintaining the shared space with care and integrity. And she's also put some links to the reports in there. Very exciting. Okay, so what else do we want to say? The recording will be available and sent out after the webinar, as will the slide deck and the meeting notes. And I think that's all I have in terms of housekeeping. So let's go to the next slide. Okay, so background of the report. Excuse me. This was a legislatively mandated report. Like zoom back in time to 2023, Representative Dave Pinto came to us and said there is a real lack of coherence in Minnesota's drug policy. What he told us was, on the one hand, there's some state agencies that are pursuing really a public health-based approach to drug use, like, for example, by funding syringe services programs. And then on the other hand, there's legislators who are hearing bills related to um, increases in penalties for fentanyl use. And these two things seem to be at cross purposes with one another. And so he said, like, is this the best way to approach drug use as a state? And seems like it's not. And if it's not, then what is the best way to approach drug policy in a way that's cohesive, where we're working together and not against one another at the state level? So his idea was to commission a report that would lay out the evidence about what we know works, what we know doesn't work, and when it comes to drug policy, like really looking at what the science and the evidence says rather than, what our gut tells us or what we've been doing for the last 50 years. So here's the statute. And the one thing I want to highlight here is the end that's bolded where it says expands individual community health, safety, and autonomy, because that was really the jump off for the methods that we took to start working on this report. Next slide, please. So, okay, we know that we're supposed to focus on health and safety, and we wanted to say, before we start off our research process, define the outcomes of what successful drug policy even means. So Representative Pinto is asking us to think about health and safety. So we said, okay, successful drug policy does the following things. It results in better health, that fewer people are getting sick or dying from drug-related causes, more people can access healthcare and treatment, that drug policy results in improved public safety, that there's less violent crime in neighborhoods and other drug-related harms, and that folks, as a result of drug policy, have improved socioeconomic outcomes like access to employment and education and housing. Um, and this might sound straightforward, but actually, this is like very different than the way drug policy has traditionally been measured. Usually, the outcomes that are being measured by scientists are things like how much do drugs cost on the street? How many drugs do police seize? Are people getting arrested for drug crimes? How many people are using drugs? But these measures don't really provide an insight into how drug policy is impacting people's lives. So Anne and I were like, okay, so we're going to look really broadly across health and safety and socioeconomic measures to get a full picture of how drug policies are affecting people and their communities. Next slide, please. So ultimately, we submitted these two connected reports. The first report was published in 2024, and that was establishing the evidence base for what successful drug policy looks like in line with the definition that I just provided. And then the second one was submitted in February 25, so just earlier this year. And what we did was we compared Minnesota's current drug policy practices to those gold standards, try to find out like where the gaps are, and ultimately came up with 150 policy recommendations for state legislators that would align our state with where we know the gold standards to be. We collected data in a few different ways. We did a literature scan looking at academic literature, which is like peer-reviewed scientific studies, as well as gray literature, like recommendations from expert groups, model laws and policies, government reports. We also conducted 49 key informant interviews with experts across Minnesota. Some of you are here today. Thanks for having done that. We aimed for diversity across the state in terms of demographics, in terms of roles, just different players in the drug policy space, including people with lived experience. And then we did a statute analysis where we mapped all the statutes that relate to drug policy and state law to find out where Minnesota's drug policy diverges from best practice. Next slide. So finally, before we dive into the findings, I want to define what we mean when we talk about drug policy. I think some people sometimes think like drug policy equals police, drug policy equals going to jail, Sometimes drug policy equals treatment, which is better. But when we say drug policy, we're thinking very broadly in terms of all the ways that drug war era policies infiltrate people's lives. So as we were analyzing our data, we sorted drug policies into 4 buckets. This was a frame developed by Scott Burris at Temple University. He's got a set of white papers called The Legal Path to a Whole of Government Opioids Response. So we used those categories. Great paper if anybody wants to take a look at it. It includes policies like also at the federal level and at the local level that we didn't look at. And then we added 2 buckets of our own, data collection and evaluation, and one which we called cross-cutting issues, which are issues that like kind of pertain to the other 5 buckets, and we couldn't necessarily slot them in one place or another. So this includes like something like funding is relevant to all the others. And then we determined and wrote into the report which interventions were supported by the evidence as being good, successful, which weren't, and which ones where we didn't have enough evidence to say in either direction. And that also we wanted to make sure we focused on racial disparities in all of these policy domains. Before I hand it off to Anne, I just want to say that some of these policy approaches are going to be very obvious to some of you here in the room, and some of you are newer to all of this. So just keep in mind that there's like a breadth of experience with these policies. And I will hand it over to my colleague.
Thanks, Ari. Good afternoon, everybody. I'm going to start with our first domain, which is harm reduction. Next slide, Bella. So for those of you who may be new to this term, harm reduction is an approach to drug use that acknowledges that society has always had drugs and drug use, and that some people are always going to be either unwilling or unable to cease their drug use at any given time, and nevertheless are deserving of health services and human rights. Harm reduction is a pragmatic approach that acknowledges the reality of the harms of drug use and seeks to reduce that harm. There are many decades of evidence on harm reduction policies and programs that show improved health outcomes. And here we list 4 biggies. Safer drug use supplies includes things like syringe service programs, distributing clean, sterile syringes to people, for example, who are injecting drugs. Overdose prevention centers are places where people can come and bring their own drugs to use them in a supervised space. So if they do overdose, there are trained people there to revive them. Access to naloxone or distributing overdose reversal medications directly to people who use drugs. This is one that lots of us have heard about and seen lots in the news lately, and has been shown to be extremely successful, particularly when given to the people who are in communities of people using drugs, who can save one another. And then our last example of a harm reduction approach here are drug checking technologies like fentanyl test strips. And these are things that help us detect when a drug supply is tainted. So if somebody is going to use drugs, they can test it first to know what it is that they are putting in their body. Next slide, Bella. This is a chart showing the impact of that very first example of a harm reduction policy or program in the earlier slide, which is the distribution of clean and sterile syringes. And this slide shows the rate of, or not rate, the number of cases of new HIV infections associated with with injection drug use in Philadelphia. And you can see the kind of orangish brownish line is the actual number of HIV cases among people who inject drugs. And in 1992, that's when the mayor of Philadelphia implemented a policy enabling the legal distribution of sterile syringes. And you can see the blue triangles, kind of that upward incline, is the forecasted number of new HIV cases. But what actually happened when syringes started to be distributed legally was that number of new HIV cases really went down. And they estimate that 10,000 HIV infections between 1992 and 2002, kind of the peak of the AIDS crisis, were averted, saving the city $250 million in public funds a year. So 2.4 billion over the 10 years. So this is just one example taken from Philly. It's been replicated in lots and lots of different cities and is an example of kind of the state of the evidence of harm reduction. Next slide. So for each of the sections that Ari and I are going to present the evidence for, we're going to conclude with a subset of the recommendations that are in the report. So here are 4 recommendations that pertain to harm reduction. And a little bit of background about how we came to these recommendations. We started with the review of the literature of what the science tells us is working or is not working. And then we looked at data in Minnesota to see what is actually happening on the ground here. And then last, as Ari mentioned at the beginning, we combined expert testimony. We talked with experts across fields. Sorry, just paying attention to distracted by the chat. And put all of those things together to say, okay, what are we missing here? What could get us closer to that gold standard here in Minnesota? So here we have 4 recommendations related to harm reduction. And I'm not going to go through each of them because we're short on time, but the number of the recommendation is on the side there. So you can look at the report and find that recommendation. And then next slide, the very exciting part of the presentation is that for each of these sections, we have a local expert here to shine some light on how this type of work is happening on the ground. So for harm reduction, we have Jack Martin here joining us. Jack is the executive director of Southside Harm Reduction Services, an organization dedicated to promoting the health and well-being of people who use drugs in Minneapolis. Under his leadership, Southside works to reduce overdose deaths and prevent the transmission of HIV and other infectious diseases related to drug use. I, in full transparency, get to have the pleasure of serving on the board of Southside, so I get a front row seat of the amazing work that Southside is doing. So I'm going to turn it over to Jack and start with a question for you. Jack, what do you want people to understand about harm reduction?
Yeah, well, first off, thank you so much for having me, and thank you for those reports. They're really amazing. Yeah, I mean, there's so much that I would love for people to know about harm reduction, and I think something that I want to recognize is that people come from a lot of different backgrounds. So, I mean, just starting with the basics of what harm reduction is, it's literally just meeting people where they're at. As Sue Purchase says, it's about reducing harm. And so through this framework at Southside, we really work to recognize the dignity, the autonomy, and humanity of people who use drugs, and people who live outside, people who engage in sex work, and experience various forms of harm. I think there's often a narrative that is around that that harm reduction is enabling, and I think that's something that's really important to just talk about, is that it's not enabling. Harm reduction is about taking a real, honest look at both the like benefits, the negatives, and everything in between related to drug uses and how that affects people and how to navigate those realities. It applies to not just drug use, but sex work, living outside, so many different things. Yeah, I mean, I think too with Southside, like there's a lot of individual based stuff. So like we distribute naloxone, we do rapid HIV and hepatitis C testing. We provide a safe space for people, provide food, provide safer sex supplies, provide education. But I think really when I think about harm reduction and what it kind of means and what the point is. I think about how one, harm reduction fills a gap in the current systems of care that exist that no other service that I'm aware of is really able to fill. So many people that we see, Southside is the only service, and this is true for other harm reduction programs too, but like we're often the only point of contact into various services that people have. Folks that we see face stigma left and right and don't feel comfortable accessing a lot of other places. And I think harm reduction programs, syringe exchanges, places like Southside, we're able to offer a bridge. One thing that we really focus on at Southside, and like I think in harm reduction in general, is working on building relationships with people over time. And that building those relationships is really important for the people that we see, but also with partner organizations. So we partner with Native American Community Clinic, we partner with John Tribbett and Vivo, we partner with Healthcare for the Homeless. We partner with a ton of different organizations and really work to build those relationships and bridge using our relationships with participants and organizations to bridge people into these different services in a way that, and working with programs that really do honor the dignity and humanity and personhood of the people that use our services. And I think overall, like harm reduction is really about improving the health and well-being of the communities that we're in. And so, and we do it in the ways that I was talking about. So yeah, I think that's really what I want people to know about harm reduction.
Thank you so much, Jack. We will have more time to ask Jack questions and hear more about harm reduction, hopefully at the end. But in the interest of time, I'm going to turn it over to Ari to take us to the next section.
Thank you. Thank you, Jack. Let's see. Bella, can you pull the slideshow back up?
Yes. For some reason, I have to do it a couple times. My apologies, everyone.
All good.
Share.
Well, maybe I'll just get started while you're pulling that up, Bella. So the next section that we're going to talk about is the social determinants of health section of the reports. Excuse me. So social determinants of health are non-medical conditions that impact people's health, things like housing, employment, and education. And I see a lot of you in this space are service providers like frontline workers, so you'll know that drug policy can negatively impact these conditions. And the reports therefore describe policies in the areas of children and families, consumer finance, education, employment, housing, immigration, public benefits, and retroactive expungement. Bella, can you go to the next slide? Next slide. Thanks. Okay, so after reviewing the evidence, we determined that the following policies and interventions met our criteria for successful drug policy. Housing First and other programs that ease access to housing for people who use drugs, expunging people's criminal records so that those felonies aren't preventing them from getting a job or whatever else, supporting families to remain together in cases of caretaker drug misuse. This space of child welfare reform is huge and so important, and we didn't have space to talk about it in depth today, but I really encourage you to take a look at the report. And finally, ensuring access to employment opportunities, public benefits, TANF and SNAP, for example, and education for people with criminal histories. Next slide. Sorry, thank you. Okay, and the flip side of that is the things that don't work that evidence tell us are not successful are just the flip side of those things. So restricting access to housing, removing children to the foster care system, policy barriers to employment, education, and public benefits, laws that prohibit public behaviors associated with houselessness, like sleeping or camping in public, begging and loitering. And then finally, fines and fees associated with the criminal legal system. Next slide. Just a little snapshot of some of the housing recommendations that you'll find in the report, but I don't want to linger here because I want to take us to John Tribbett. So John is the service area director for Avivo's Ending Homelessness Division. He oversees emergency services, including street outreach, Avivo Village's emergency shelter, and the harm reduction team. With a deep commitment to saving lives, John leads efforts to support individuals experiencing homelessness, substance use, and complex barriers. And Avivo serves 11,000 people a year. So John, thank you so much for being here with us. Just to dive right in, because we don't have a ton of time, what is the number one barrier to individuals seeking housing and accessing basic needs?
Yeah, well, thank you, Ari, and thank you everyone for being here. I think the simplest answer is housing is the biggest barrier, and having enough housing. Some recent reports that came out from Minnesota Housing Partnership said there's only 39 available units for every 100 individuals in the state that are households that are extremely cost burdened. We're over 100,000 units short. So despite the fact that we do hear about a lot of affordable housing being built in different communities, which is wonderful, the reality is that for deeply affordable housing, and then even more nuanced, deeply affordable housing that actually works for people that are dealing with complexities and acuities, which include, MOUD and substance use disorder. We just simply don't have enough places and enough of the support and service networks to have people remain housed.
So true. So simple and yet so complicated at the same time. What does Housing First mean to you, and what are the impacts that it could have on folks?
Yeah, so I think somewhat like Jack described, harm reduction. I think at its most fundamental level, Housing First is functionally meeting people where they're at and understanding that without a stable place to rest at night, to become, comfortable within your own being, with having friendships and partnerships and romantic relationships, without a basic place to live your life, it's really hard to work on the higher order things in our lives. I'm very comfortable in my life, and I have a hard time working on a lot of things that I would like to do better in my life.
Yeah.
And so when people are stuck, oftentimes quite literally in their brainstem and in survival responses, having a place to lock a door can help people move into the frontal cortex and literally change the biology. Mm-hmm. And it's a revamping ultimately of an old methodology, which unfortunately I think we're starting to return to, which is that you earn housing by, crossing a number of finish lines that are very, very challenging once again when you're outside. And instead of that, it's saying, hey, your qualification for housing is, you deserve a home, period, full stop.
Could not have put it more beautifully myself. Thank you. I wish that we had more time to talk with you and everyone here about all the brilliant work that you're doing. That is not only the right thing to do, but is so deeply rooted in the evidence and what the literature tells us works. So thanks for being with us. I fully encourage everyone to take a look at the Avivo website and the Southside websites that Bella has put in the chat for us. All righty. So I think the next thing that we're going to do is move to healthcare.
All right, our third domain of drug policy is healthcare. And I'm going to start by saying that substance use disorder is widely recognized as a chronic disease. And while this disease model is sometimes debated, most of the evidence, the strongest evidence that we found in doing our lit search, were in the domain of healthcare. So here are the top things that evidence showed worked towards successful outcomes in drug policy. Medications for opioid use disorder. This is methadone, Suboxone. Substance use disorder treatment that is voluntary, available on demand, culturally appropriate and geographically accessible. Medicaid coverage for treatment of substance use disorders, so making sure people can actually get to it. Peer support and recovery coaching, the idea that people who have lived experience are sometimes the best positioned to be able to offer support. And across provider types, increased competency in knowledge around how to work with people using drugs. Next slide. This slide shows some of the things that evidence does not support when it comes to the healthcare domain. Compulsory treatment, this idea that people have to complete treatment before they're able to ... whether it's hepatitis C treatment, housing, for example, not effective. Involuntary civil commitment, policies that require prior authorization. This is an insurance mechanism that slows down people's ability to access care. Policies requiring abstinence, drug screening, or counseling before initiating various types of treatment. Also kind of these things that just get in the way of people being able to just start when they're ready. And prescription drug take-back programs. These are all things that evidence show don't really lead to those three types of outcomes of what we're defining as successful drug policy. Next slide. Again, like we've shown you in the other sections, here are a handful of our recommendations. There are many, many more in the report. These are just the recommendations regarding expanding access to medications for opioid use disorder. And I am very excited that for our guest for this section, we have Dr. Lauren Graber with us today. Dr. Graber is a family medicine physician specializing in addiction medicine at Hennepin Healthcare, with a particular interest in families, pregnant people, adolescents affected by substance use. Dr. Graber was also a member of a governor-appointed task force that prioritized the recommendations that you're seeing here in these reports. And I got to know Dr. Graber a little bit during that process and was just always impressed by the way in which she thoughtfully treats her work and clearly regards her patients with dignity. And so without further ado, I'm going to turn it over to Dr. Graber.
Thanks so much. I'm really delighted and honored to be here. I hope, give me a thumbs up if you can hear me okay. Is my audio all right? Wonderful. Well, gratitude to everybody on this call and the willingness to really look at some of these recommendations and research-based ideas and how we can do this better in the state of Minnesota. I was going to share a little bit with you all something that's been really helpful for me in my practice and actually a tool that I use directly with my patients. I am that geeky doctor that like draws out a graph for people because I often am asked a question. I wonder if some of you have the same question about like, why do medicines for opioid use disorder even work? Like, isn't it trading one drug for another? And aren't you just giving people another crutch? Like, what's that all about? And I really wanted to say about why like it's so different than that and why these medicines are so effective in saving people's lives. So I'm gonna show you my dorky graph. Get ready for it. I hope, give me a thumbs up again if you can see it. Is that looking good? Okay, great. So from the moment that we're born, our body does make natural opioids. Some people call these endorphins or endorphins or like stress hormones and these different things that you create this natural level that your body is used to. And it goes up and down. Some of those higher moments being moments that you have of like great joy with your family by you, and times when you're more isolated as an adolescent, perhaps that level is a little bit lower. But in general, you're setting yourself up for this like baseline of a natural opioid level that your body's used to working with and we're used to functioning with. And I will say, like, trauma and other things do change how those levels go. And that's not really reflected in this graph in the same way, but it does make some people more vulnerable. And so then the first time people try an opioid, either a medication or an illicit substance, for a subset of people, not everybody, it's really an outsized response. I call this the heck yeah moment. It's like better than any like super great feeling you had before. It just is like an amazingly different experience. And especially if you've had hard things happen to you, This really makes those hard things feel inconsequential and helps and can help people really feel like they're managing life differently. And so it's a really natural human response. And we've seen this with, all sorts of animal studies too, that when you have that response, you're like, well, I'm going to try that again. And you do, except it's not quite as good as it was the first time. So you're going to take just a little bit more and see if you can get to that same level. And so, but what starts happening is you're kind of trying to chase to get to that heck yeah moment. But instead, your body, as you take these opioids, from another source, your body's endogenous, your own natural producing opioids decrease. Because your body is like, oh, you're getting it elsewhere. Well, I don't need to make that anymore. And so what happens is that then your body's not making those anymore. And then in those moments, suddenly, when you're not using, the low you're feeling is way lower than that isolated teenage self. This is way lower than desperation, despair. This is horrific, horrible withdrawal, non-functional, aching body aches all over, horrific anxiety, depression, and an inability to do the things that you need to do. And so suddenly you're not even thinking about heck yeah. You are really looking at, how do I get to my normal baseline? How do I feel normal? How do I get my kids to school? How am I going to show up for work today? How do I make this happen? And that, everybody, is what methadone and buprenorphine do. They get people to the baseline. They are not getting people to heck yeah. And I think that a lot of people are worried about the side effects and like how that looks, when people have methadone and like what people are seeking. Let me tell you, for the vast majority of people with opioid use disorder, having access to these medicines means they go to work. It means that they get their kids that they get their kids on time to school. It means that they're able to do the things that they want to do to be a successful human. It is giving an opioid to someone who has opioid deficiency. It is giving a thyroid hormone to somebody who has thyroid deficiency. It's like giving insulin to somebody with diabetes. This is getting people to baseline. And so as a provider, I just wholeheartedly support the work of these recommendations, that these medications save lives, give people back full and fulfilling life work, and that we in this state of Minnesota have this amazing opportunity. We can allow people to have better access to these medications through every corner. That means methadone at other sites besides only methadone sites. We can be creative about how to get people these medications to make it work, and that we can partner with them. That even in the moment, if somebody's on a medicine like buprenorphine or methadone, even if they have a return to use, having those medicines on board makes it safer. It makes it safer for people to have to make mistakes, to have blips in the road. These medicines it's not black and white, you stop and start. Like, this is about keeping people alive and getting people the support where they are. And it is, as we were saying, my joy and specialty is working with pregnant people, adolescents, and families affected by substance use. I really, in my heart, believe so many people who are struggling with substance use disorder want to be different parents, and that we have an opportunity to give them a medicine that actually allows them to do this. This is a wonderful thing. And as a state, we've done a lot to educate providers across the state. But both me and my colleagues here at HCMC lead statewide info sessions and education sessions to educate providers. And folks, we have so much more to do. This is a big state with a lot of little nooks and crannies. There's a lot of work that we can do to make this work better. And so I just really appreciate the partnership of everybody on this call.
Thank you so much, Dr. Graber. That was fantastic. I want to steal this slide. I'm going to turn it back over to Ari for our fourth domain, drug policing.
Thank you. Just love that presentation. It's so good. Okay, so our next domain is drug policing. Drug policing is an umbrella term that we're using here to capture the ways that drug use and drug sales in the US have been addressed for the last 50 years using a really punitive enforcement-based approach that is often called prohibition. So what do I want to say? Sorry, I have my notes are a little funky here. Okay, so what the evidence told us was working to improve health and safety were decriminalization, which is a word that has a lot of baggage, but essentially what it means is removing criminal and civil penalties for drug use, and then diverting people to health and social services. Defelonization, which means downgrading personal possession from felonies to misdemeanors, diverting people to drug treatment. This is for people who need it, and that's tailored to the individual, and then commuting sentences. So these are the things that work to increase public safety and to increase public health. And there's lots of great examples in the report of the mechanisms for doing this. So the things that didn't work, next slide, thank you, are arresting people for drug use, criminal repercussions for simple possession, imprisoning people for drug use, laws that criminalize drug paraphernalia, drug-induced homicide laws, opioid-related drug seizures. These are the things that we've been doing for, I don't know, 50 to 100 years and have not worked. And they will continue to not work the more, even as we try to ramp them up. So next slide. Let's see. All right. I was thinking about maybe skipping this, but I think, do I have time? I think I do have time to just do this very quickly. So this is,
Yes.
thanks, Bella. So I just wanted to emphasize how deeply what I just said is rooted in the evidence. So this is a chart from a huge meta study that looked at 106 other studies and combined the findings from all of them to look at what was the impact of criminalization. So criminalizing people for their drug use on HIV prevention and treatment. So the proxies for criminalization, you can see on the left-hand side of the bar chart are things like restricting access to what we used to call opioid substitution therapy, and now it's called medications for opioid use disorder, a whole controlled substances laws, incarceration, these are all the ways that the researchers were thinking about criminalization. Next slide. And these were all the proxies for HIV care, like HIV testing and treatment and syringe sharing and drug injecting. So what this chart is showing essentially is that the red bars are places where criminalization had a negative effect on HIV prevention. Blue is where there was no effect, and green was there was a beneficial effect. So looking at this whole thing, it's showing that criminalization had a beneficial effect on syringe sharing in one study. Criminalization had a detrimental effect, meaning it increased syringe sharing in more than 30 studies. So looking across these 106 studies, 80% of study outcomes suggested that laws criminalizing drug use have a negative effect on HIV prevention and treatment. So when you're asking like, well, how do they determine that decriminalization, is the right thing to do? This is one example of the many, many, many studies that Ann and I looked at to say, look, what we're doing is not working. Next slide, please. And then again, just like a subset of the recommendations that we have. Next slide, Bella. Yep. And I think you can go to our spotlight on Jason Urbanchik. So thrilled to have Jason here to speak to you all today as the spotlight for the drug policing section. Jason is originally from Detroit. He now lives in Moorhead. He's the son of a police officer, and he brings lived experience with homelessness, substance use, and the justice system, as well as incarceration. He is a former community engagement fellow with the Minnesota Coalition for the Homeless. And he leads advocacy efforts through the Fargo Coalition to End Homelessness. He's with Homes for All. He does many, many other things. Jason is driven by years of surviving a system that failed him, and he pairs his advocacy work with active work in addiction recovery, and he has recently celebrated 6 years sober. So thrilled to have Jason here, and he is going to read a prepared statement.
Thank you very much, Aria. I'm actually coming up on 7 years here in November, so it'll be wonderful.
Right on.
All right, good afternoon, everyone. I would like everyone to picture a map of Minnesota. Moorhead and Duluth anchoring the borders, river towns and reservations stitched together. Now imagine a thin red line running through it. Our response to drugs. For years, that thread is pulled toward punishment, Today, I ask us to reweave it toward health, safety, and dignity. Here's the heartbeat of the report's drug policing section. Punishing personal possession hasn't delivered safety. It's delivered criminal records, strained families, and deeper undergrounds where overdose becomes more likely and help harder to reach. We can keep going, excuse me, we can keep doing what doesn't work or choose what does. Let me walk you through a few scenarios. Scene 1, the kitchen table, a friend overdoses, someone hesitates to call 911, afraid of police response. We can fix that fear. Legalize sterile syringes, safer smoking supplies, and drug checking tools. Repeal drug-induced homicide laws that punish grief and deter help. Stop reflexive scheduling changes that don't make supply safe. They don't make supplies safer. Tools, trust, and information do. Scene 2, the courtroom that calls itself an alternative. Treatment courts can help, but only if they follow evidence and equity. Programs must be statewide, accessible, and measured by outcomes that matter. Supervision should stop turning relapse into punishment, and universal drug testing that sets up people to fail. Recovery isn't a straight line. Our response shouldn't make it a trap either. Scene 3, the sentencing grid. I know this all too well. Minnesota's framework has produced disparities in time behind bars that don't align with public safety. The report calls for a comprehensive review to reduce racial disparities and realign penalties with evidence. Build in resentencing pathways where past rules caused outsized harm. Justice can learn, policy can evolve. Being in prison, you can see the racial disparities. It's very overwhelming when you look at it. Scene 4, the parking lot outside of a prison. Someone is released with nothing but $200, a bus ticket to an unknown community alone. That was me. Off-ramps only work if they exist. Fund and scale diversion programs from first contact to case dismissal, and most importantly, aftercare. Make it simple to step off the criminal path into a path of recovery. When help is easy to reach, people reach for it. If these things sound bold, they are, and it's also practical. We know what works. We know what better looks like. Fewer arrests for possession, more people choosing care because the door is open. We can narrow the racial disparity gap that decides who is punished and who is helped. Plain and simple, less people die. You might ask about accountability. Accountability without effectiveness is just noise. This approach is accountable to results. Are people safer? Are families more stable? Are overdose deaths down? Are disparities shrinking? If yes, keep going. If not, adjust. That's real accountability. Thinking back to that map at the beginning, policy becomes real in living rooms, clinics, patrols, patrol cars, and probation offices. The laws we write shape the choices people have in crisis. Call for help or don't, carry sterile supplies or don't, return to treatment or return to court. We design those choices, we can redesign them. So here's the invitation: decriminalize personal possession and social sharing, legalize life-saving supplies, replace reflexive enforcement with community responders, hold treatment courts to equity and evidence, and universal drug testing. Build true off-ramps, review sentencing with racial equity as a North Star, resist symbolic scheduling, pursue strategies that make supply less deadly and care more available. Minnesota can be a state where reaching for help is easier than falling through the cracks, where policy is measured in lives kept, not lives kept out, where that red line, where that red thread becomes a lifeline we choose to weave together. Thank you. Let's save some lives.
Jason, I think you have to be also a poet or like an orator or something. That was just incredible. Thank you so much for sharing your perspective with us.
Thank you very much.
Dang, I feel like, oh, I was just gonna say, I wish we had closed there because like standing ovation and then the webinar is over. Unfortunately, we have to talk about data collection. Sorry, Anne, to follow that. You have to follow that.
What an intro. I will be super quick since this is everybody's favorite topic. Just to say that we can create drug policies that truly improve health and safety, but we need to be able to measure them accurately to know that it's working. So we have a handful of recommendations in our report that gets at better ways to measure the impacts of drug policy on people's health, safety, and economic outcomes. And Minnesota has made some progress on this. For example, we now share overdose data with the Overdose Detection Mapping Application Program, known as ODMAP, which can generate real-time insights into when and where overdoses are occurring, not just fatal overdoses, but non-fatals as well. But there is still a lot more to be done. Here are a handful of those recommendations, and in the service of time, I'll kick it right back to Ari.
Thank you. Okay, so the last section we want to run through quickly is what we called cross-cutting recommendations. So again, these are recommendations that apply to multiple policy areas at once rather than kind of slotting in neatly into any one place. So this section contains recommendations about certain populations that are about funding mechanisms. And I think there's some stuff about including people with lived experience as drivers of policy. So just as one example, like Native American communities identified policy needs that affect both healthcare and harm reduction, so they live here. And again, Minnesota has made some progress on culturally specific care. There's a 2023 Comprehensive Drug Overdose and Morbidity Prevention Act that dedicated state funding to culturally specific programming. But a lot of work remains. Next slide. So before we wrap up and have time for a few questions, this image shows what the recommendations look like in the report. So the top line is what's in the narrative. So in the body of the report, you'll find these like abridged recommendations with potential impact, key state partners, primary outcome, and primary impact. And then if you go down to the end of the report to the appendix, that's where you will find a really detailed recommendation. It will link you to the evidence behind this recommendation in the year one report. There's like a bunch of guidance, like including model drug laws, places in Minnesota statute, guides for governors and state lawmakers. Like there's a lot of really good stuff there. Next slide. So this is where we'll leave you. Essentially, the decades of research show that criminalization of drug use does not lead to improved health and safety outcomes for Minnesotans. And that instead evidence points in the direction of support, including to treatment access, harm reduction, services, housing, and employment, and off-ramps from the criminal legal system as the best way to keep people in their communities healthy and safe. So as you begin planning for the 26th legislative session, we hope that you consider these 150 recommendations, evidence-based recommendations, as a jump off. And that is it from me and Anne. And I think we have 7 whole minutes for questions. Bella, do you want to grab a question or two from the chat?
Yeah, I would be happy to. Just give me 1 second to generalize some of these.
I can start by looking at some of these. Okay, so from Brian, I see, do you have an idea of who will be taking up some of these recommendations for legislative proposals? Representative Pinto, DHS, or others. I'll share with our March work groups for review as well. Thanks, Brian. We are in the beginning of planning some of these things. So I'm going to take off my research hat now and put that aside because I also wear an advocacy hat at Impact MN. So I can say that, first of all, the task force that Lauren was a part of reviewed a bunch of these and put their stamp on a handful, not really a handful, many of these recommendations as ones that they think the legislature should take up. So that is one place that they are moving forward. We hope that the legislators read them. I also know that Impact MN, a group where I am a coalition administrator, is working on some of these. For example, on SNAP, there is still a clause that says that people with drug felony convictions are subject to random drug testing for 10 years. In order to access SNAP, we think that's discriminatory, and the evidence shows that it doesn't help to prevent people from being able to eat. So we'll be working on that as well. But like, there's so much here. This is such a huge topic. We need all hands on deck. So for those of you who are offering to bring these recommendations to your to the different tables that you sit at, thank you. Let's see, I can,
I just
keep
messaged you.
looking.
Ari.
Sorry.
I just messaged you a comment or a question. Rather.
Okay. Okay, Bella says, someone expressed concern that advocating for the repeal of drug-induced homicide laws could make it harder for advocacy. So just to reiterate again that this is a research report, it's not an advocacy document. What we are saying is like, here's what the evidence tells us about some common drug policy practices, about whether they work or don't work. So we're not saying that, oh, I'm getting a recharge headset. I hope I make it 4 more minutes. We're not saying that this should be like the headline of your advocacy campaign. What we are saying is that the evidence shows that it's not effective in terms of increasing public safety and public health for Minnesotans. Let's see, what else do I have? I answered that one. I see that Kyle has a question about immigration. One of the biggest challenges is the gap between Minnesota reform laws and federal laws, which has significant consequences in immigration court. For instance, automatic retroactive expungement is harmful for folks involved in immigration proceedings. I am curious how we can uplift all, while holding space for Black and brown folks who have additional collateral consequences federally. Oof, that's a good question. I wish I had more to say about this, Kyle. It's not my wheelhouse at all. I know that you are the expert on this, actually. But if you have ideas about how to work on that, I would love to hear them.
No, I'm trying to echo this in every space that we go into, especially seeing the ways that drug policy is specifically used to criminalize immigrants and has been one of the leading causes of deportation historically. And just ensuring that that's part of a harm reduction conversation in terms of the capital H harm reduction systemically. But I want to hold balance for it, you know?
Totally. And there is a whole section on immigration in the reports. Please take a look and see if any of that is useful. We are also conscious of like the Trump administration's focus on immigration and drug use and homelessness. We know all those things are kind of like caught up with one another. So I think this is certainly a place that we want to all be in conversation with one another in our, break down the silos as much as we can. I think that we are just at time. I'm so grateful to all of you for having spent time with us. Thanks again to our guest speakers, to Bella for running tech, and we hope to keep the work going with all of you. Thank you.
Thank you, everyone.
Thanks, everybody.
I think my headset is going to just make it. Yes, I'm just seeing your comment. We did add language access. That was one of our recommendations, and you're right. Thanks, everyone. Nice to see you, Keisha and Edward and Sarah and Damon.